Everybody, this is Professor Butler, and this is going to be your lesson on growth and development of the school age child and the adolescent. So, these are the main things we'll be talking about today, not necessarily in this order, but sexual development, also known as puberty, physical growth of both age groups, social and behavioral development, hygiene, nutrition, and childhood obesity, safety, and behavioral and cognitive disorders. I want to start off in talking about school. School is vitally important during this age time. Obviously, this is the time when they do go to school. The school's role in the health of our children is basically through meals, education, screenings, and services provided while attending. The whole school, whole community, whole child (WSCC) is a model that the CDC uses as a framework for addressing health in schools. This model is student centered and it emphasizes the role of the community in supporting the school and the connections between health and the academic achievement using evidence based policies and practices. There are a lot of things that they offer through school programs and services to children, including psychological, um, medication administration, screenings, and also nutrition. So before we get into the different ages and stages for both of them, I am going to talk a little bit about some common things we see during this age group, both adolescents and for school age. So ticks. So I don't know if how many of you guys have ever seen a child with a tick. Sometimes the ticks are so subtle that you can't really tell that the child is having a repetitive tick. So ticks are an involuntary, recurrent, random, rapid movement or a vocalization done by a child. They can come and go. They are usually very harmless, but they have this sort of, my way of putting it's like an itch that you have to scratch. Because a lot of times parents aren't educated on ticks and how common they are. And then the fact that they usually do just go away and that they should not really be scolding the child for blinking their eyes or um, picking at their hair or eyelid or whatever the case may be. Because ticks usually are in the upper extremities and on the face. So there's things that they usually are doing on the upper end. Now, again, we can have vocalization, which can go into a different type of tick called Tourette syndrome, which is also TS. But anything that goes on for over a year goes into another realm. So then it's kind of diagnosed as a chronic condition versus just something, a usually harmless tick. So simple, we have simple ticks and we have complex ticks. So simple ticks are the eye blinking, the grimacing, the neck jerking, the shoulder jerking. Those are little things that the child does. And again, these things can go away. Now, complex motor ticks are they can be jumping, squatting, stamping their foot, swinging their arms through the air, hitting or biting themselves. So it can get really aggressive. But again, this is something that's involuntary. This doesn't mean that the child is a harm to themselves or to others. This is a neurological condition. And there are neurological specialists that do specialize in this area. Medications can be given if it is necessary. I've listed two of the most common medications. These medications can be um, sedative, so we have to be careful about when we give it, how much they give, and if it's really warranted. Anytime we give a child medication, it's also important to put the child on some type of behavioral therapy because having a chronic tick can be very debilitating from a social standpoint. And we want to not only support the child, but sort of support the family as they deal with these repetitive ticks as they come and go. All right. So I talked a lot about tics, but Tourette syndrome, as you can see, is it's kind of different. So when they start vocalizing, and it could be swearing at times as well, then that kind of goes into Tourette syndrome. Again, there are specialists who can monitor this. Unfortunately, when it goes to Tourette syndrome, it could be something that's more permanent, and medication and therapy is really warranted at that time. The next slide shows you is just this is not mandatory. This is an optional thing, but this is just a little clip of a news report on ticks in children, and it's not that long. So the next thing I'm going to talk about is ADD and ADHD. And attention deficit hyperactivity disorder refers to the developmentally inappropriate degrees of inattention, impulsiveness, and hyperactivity. So the H in the ADHD obviously stands for hyperactivity. Some children have that and some children don't. Some children just have the attention deficit disorder. So it's important to diagnose which one that they have. And usually it's pretty obvious. The cause, regardless of which one that they have, is kind of unknown, but there is a 50% chance if a parent has ADD or ADHD or some type of attention deficit, that usually children are going to have that as well. It is one of the most common neurobehavioral disorder in childhood, and it affects millions and millions of school-aged children. It is seen more frequently in boys than it is in girls. And as you can recall, possibly from your neural pathophysiology, it has a lot to do with the norepinephrine and dopamine or serotonin receptors in the brain. And so sometimes these are not as receptive to the hormones. Therefore, they lack the ability to focus and to stay on task. Diagnosis is usually made when six or more of the symptoms occur, and there is an actual chart in your book, and you can take a look at that. So basically, when six or more of the symptoms occur and they are present to a degree that is inconsistent with the developmental age of the child. All right. So that means this child is having these symptoms for 6 months or more, and they're not really meeting their developmental milestones. Okay. This can become a major developmental issue both at home and at school, as you can probably tell. It is important to not label the child and to allow them to get proper treatment. Again, behavioral therapy is the first line of treatment before we place a child on some type of stimulant, because that is the actual medication that we do, and then titrating the stimulant up for adequate dose for them during the day and also at night, because a lot of times we put them on the stimulant and it's okay for them during the school time, but then we have to counteract it with another type of medication so that they can sleep at night. So it is a delicate balance as they grow and as they, become more in tune to what their body needs in order to function properly in school. It is given 7 days a week. So a lot of times, and I've had lots of conversations with families about this. So what they want to have what they call a medication holiday. And the medication holiday is like during the weekends, they want to just not give them that stimulant, right? They don't want to drug their child and have them dealing with the ups and downs of these medications, but it's really important for their body to stay on a normal routine of getting the stimulant or any other medication they need in order to sleep. Right. So monitoring their sleeping, giving it routinely every day of the week, and as well monitoring our weight. So one of the things about these drugs is that they really make you laser focus, but your metabolism and their adrenaline can actually get higher, and so they burn a lot more calories. And remember, these children are growing, so they can actually lose a lot of weight. These drugs are used irresponsibly sometimes in order to lose weight and to be able to stay up and cram and be able to take in a lot of information and prepare for major exams. So monitoring their weight is crucial. There are guidelines in place that if they don't have a certain weight or they reach a certain weight loss, then they're automatically taken off the medication. So again, it's really important to monitor these children, and it's considered a controlled substance. Okay. And then lastly, I want to say that they usually have some other type of disorder associated with ADD or ADHD. So we have a child who is diagnosed with that. They'll screen them for, excuse me, other disorders that they may have as well. All right. So next I want to talk about learning versus intellectual disabilities. So learning disabilities consists of three characteristics: lower intellectual ability, It has to happen before age 22, so there has to be a child onset. They also there's a significant impairment in social functioning or adaptation. So learning disabilities can come in multiple forms, right? So I have there listed a lot of this stuff. So dyslexia, dyscalculia, dyspraxia, etc. So these are specific to the area where they are having some difficulty in learning. And it could also include a deficit in some formation as well. So children with auditory perceptual deficit can appear to be unable to follow directions. Children with visual perception deficit may have difficulty reading and lining up numbers for mathematical operations or judging distance appropriately. They usually are like children who have dyslexia, for example. That's a common one we hear about a lot. Children with integrative deficit may have difficulty sequencing data or storing or retrieving sensory data. So they have to use like a multisensory technique in order to be able to comprehend what's being instructed to them. All right. And then there's also motor deficits. So sometimes children may need to use special devices or computers because they are unable, from a fine motor standpoint, to write appropriately. That could be a learning deficit because they can't actually take notes. So we have to actually use other things so that they can take the notes and do the things so that they can use that information later to study. So, the Learning Disability Association of America provides information and support to families. So, whenever we have a child who possibly has some type of learning disability, they are a wonderful, wonderful resource for parents to be referred to so that they can get the support that they need in order to do whatever it is they want to do. Okay. So now let's go to intellectual. So intellectual disability is also called cognitive impairment. So they're used interchangeably, and it basically could be a host of different things: an infection, a accident, a hypoxic episode. All in all, this impairs intellectual function and the ability to adapt due to whatever was the cause. And this happens before the age of 22. So again, pediatric onset. I listed here the IQ is usually less than 70, but this is becoming less used for diagnosis purposes, but it's still out there. So we're going to go ahead and keep it on the side for right now. Intellectual disability or cognitive impairment can range from mild to profound. And as I said, impairment causes vary. So a hypoxic episode could be a child who lacked oxygen when they were born due to some type of episode at birth. These children also could possibly be diagnosed with cerebral palsy, also known as CP. In utero, if they were exposed to some type of drugs or narcotics or whatever the case may be, that could be the cause of their intellectual disability. Any type of genetic abnormalities or syndromes, or possibly the mom got infected with rubella when she was pregnant, which can definitely cause birth defects. So these children come into our care, and we have some nursing considerations that we do need to think about from the school age standpoint. So understanding that screening is very important. So that chart that I talked about in the past lecture, where we have all these different screenings that we use in order to see if there's a possible concern that we need to kind of follow up on. It's so and the best thing to do is always ask age appropriate question. Always ask age appropriate questions. It's not small talk, it's screening. So, what what grade are you in? What school do you go to? When I ask all those questions, I'm trying to see if this child is where they're supposed to be. I see their age because I have their date of birth. And I want to see if they are actually progressing. How do you like your school? Do you play any sports? So these questions are great to kind of get people to warm up, but it really is it's kind of a screening method to see, is this child achieving or at where they need to be? So if not, we always need to assist with identifying disabilities, any referrals. asking the parents, are there any concerns? Are they having issues in school, etc. Um, and then we might have to adjust care for these children, right? And be because these children might need IEPs. They need to have some health promotion conversations on how do they do their own self care, right? Allowing them to participate. What are ways that we can enhance not only their participation but their communication? If a child is having some issues as far as like language development, we can put things in place until speech can really get that worked out, right? Overall, what we're trying to do is optimize their development and adjust things accordingly. Now, there are some red flags I do want you to know, if I haven't already mentioned that, when we have a child who is failure to thrive, so that's a nutritional deficit where the child is really not on the curve where they're supposed to be. And also their lab work may be showing signs that they are really malnourished. So this could actually be a sign of autism. Also, if a child's head circumference is a micro or macrocephaly, which just means abnormally big or abnormally small for their age, then that also could be a sign of autism as well. Always do a complete neural assessment, refer to your specialist if you suspect a disorder, advocate for this family as much as possible, and always follow up. If they are hospitalized, it's important to ask what you could do or what you should or should not do so that you don't set them off, especially if they have a cognitive issue or autism. What was their birth history? I've talked about that before because a birth history can tell us a little bit of why they're in the situation that they're in. Document their milestones or lack of milestones. Always follow up on the metabolic screening results. Ask about it because maybe it fell through the cracks and there could be some genetic syndrome that we don't really know that we could follow up on that at that point. When all else fails, we always get a CT and always check for thyroid function tests because a lot of these things, okay, so CT is looking for anything from a neurological standpoint, like a brain tumor, just so you know, or anything that could be explaining behavior issues with a child. And even if a child had a hypoxic episode, we can see that on a CT. Thyroid function tests will let us know if they have like hypothyroidism or hyperthyroidism, right? Or otherwise known as Graves' disease. This is important because a lot of these behavioral things that we're talking about could be manifestations or mimic manifestations of thyroid disease. So always a thyroid function test is important to rule out any other possible causes. All right, now we're going to go into puberty. So, as we all know, sex is a normal part of development. It is very natural for children to be very curious about their bodies. And actually, this starts in preschool and toddler bill before it actually gets to school age. But this is where the rubber meets the road, right? This is where children are really need to learn about their bodies. They need to learn what is appropriate. They need to know the names of their bodies and so forth. So this slide really talks about what are some of the things we need to talk about sex. And believe it or not, they love to talk to nurses about sex because sometimes families are shy to talk about sex, right? Just about sex. There's a lot of things that families do to try to, move her away from talking about sex. Or you could have that family member, which I would gladly use myself as an example, who says, "Oh, do we need to talk about sex? Oh, let's talk." And my daughter is doing exactly what you see there on the picture with the kid. And she's just like, "Oh my God, mom, you're using words that I really shouldn't hear." And I was like, "What? It's called masturbation, right? Or it's called a sex, or no, no, that type of sex is sex, okay? Just because you don't penetrate doesn't mean it's not sex." And then, I used to do it when she was locked into the car and she really couldn't get out, so she had to listen to me. Um, but they get their information from the internet, they get their information from books, and they get their information from sources that we know that they are not the best resources, right? So they have a natural curiosity, and we want to make sure that they get the correct information. At that stage, it is masturbation is very normal and common, especially for boys, but girls do as well. it's important for them to learn the correct names because I can't tell you how many grandma, grandpa, or whatever the case may be have all these little names that they call the vagina and the penis and so forth. The kitty cat, the down there, what did there was another thing a student said in a class. I was like, oh my gosh, I haven't heard that. So they just don't want to say the name because if you say the name, then they just feel bad. So that's an older generation thing. So they need to know the names of their body parts. Sex play is normal, and playing role playing and stuff like that, things that they see on TV, and not shaming them, and just getting them to understand the concepts of sexuality and then also sexual behaviors and what is appropriate and what is not appropriate. Sex education starts in school usually, hopefully. I've heard some things that they've actually had some sex education in late elementary school, I think. And I thought it formally, oh, that should be formally, sorry about it. Formally, a formal education begins in middle school. But anyhow, the whole part of they have sex education, but parents can't opt out of it. Parents can say, I don't want anybody talking to my family about sex. And that doesn't necessarily mean that the teachers are doing a good job either. All right. So all this to say is that you need to kind of do a self-assessment if you're going to work with children, and teenagers, because it comes up, right? They will ask you all type of questions about everything, and you have to be comfortable um, talking to them. All right, so let's talk about puberty. Okay, so let me just say this. So this always gets a little bit shaky. So puberty technically begins for girls at age 10. But there are pre-puberty things that happen can start earlier for 2 years beforehand. So puberty can start as early as age 8, between 8 and 9, or 10 to 12. So if and remember, it begins when they start to have their period. Okay. So when they have their period, that's technically when they've hit puberty, right? So it was like when they hit puberty. Um, for the boys are usually 2 years after the girls. So usually boys will start at 10, and then they're considered hitting puberty at age 12. So I hope that's very clear there. But I'm going to say this though, it's a slippery slope, right? Because we never know really. I mean, there are lots of things that we're going to talk about that can actually cause puberty to start earlier than that. Earlier than that. So, unfortunately, um, we're on this thing where there is no clear answer exactly when puberty starts, but for the test purposes, for girls, pre-puberty starts at 8, puberty usually begins at age 10, and the boys are usually 2 years behind that. Okay, so that pre-puberty for them starts at 10, and then puberty hits at age 12. So we're gonna use that for right now. All right. So, before we move forward, as we're talking about puberty, I want to say that in the chapter that has health problems associated for the adolescent, you're going to see a lot of sexual disorders for the male and the female that are not going to be covered here. They were either covered already in another class, like STDs, or they're going to be covered in OB. All right. So for women's health. So you're just going to be responsible for going back and reviewing like eating disorders. That's another one, and mental health and sexually transmitted diseases. All right. So that's going to be really important. There are some male testicular and penile problems that we will be talking about in the GU lecture, but we won't be talking about here. All right. So puberty process. All right. And the Tanner stages. So when we are assessing a child, in order for us to kind of stay on the same page and use our standardized assessment, we use the Tanner stages. But first, before that, let's talk about what happens during puberty, right? In puberty, we have a term primary sex characteristics and secondary sex characteristics. Secondary sex characteristics are the ones that you see there in the box. right? These are things that happen that are associated with puberty. Remember, it's a neuroendocrine process. So you see there, this, let me get my cursor. So this is a chart that kind of basically tells you the flow chart of the hormones and the triggers and what triggers what. So you starts in the hypothalamus. GnRH is triggers the anti-pituitary that releases FSH and LH to the gonads, and then estrogen and testosterone is released. And then you have these things happening: your primary and secondary sex characteristics, creation of sperm, and the release of the egg. All right. So things are dormant until a specific time, and then it is believed that the receptor sites in the hypothalamus um, are so sensitive that minute quantities of circulating sex hormones are sufficient to inhibit the secretion of GRNH during childhood. But then it loses its negative sensitivity at puberty, and that allows that whole mechanism to occur. All right. So sex hormones are the estrogen, testosterone, but also don't forget about the progesterone as well. And again, these sex characteristics that you see here are the growth of pubic hair. That's one of the things that we're going to use to assess. These are things outwardly that we can see: breast development, testicular enlargement, penile enlargement, um, increase in body hair, body odor, right? Increase in fat mass, lean muscle for the guys, fat for the ladies. Lovely, right? But these are things that we can see on assessment and we can tell, oh, yeah, they're going through puberty. But then we have to stage them, because it's important to stage these children so that we have an idea that they are developing not too fast, but also not too slow, because that can tell us that there could be something going on. So the larche, which is the breast development, we look at, for the guys, we look at their breast bud stage, we look at their chest, and for the ladies, we look at their breast. And so here are the stages and the actual descriptions. And you're not going to have to look at somebody's breast to actually see, to describe this person's at stage 3. I'm actually going to give you these descriptions. So you want to look at this and and study: stage 3 is this for male, stage 3 is this for female. Okay. And so this is very straightforward, right? So as they continue along on the stages, you can see more breast development, as well as the areola is becoming more pronounced, and also the coloration becomes more darker. So that's the larche. And then we're also going to talk about pubic hair. So this is why we peek in their peek at the bottom to see if they have any pubic hair, to see what it looks like down there. And it goes from stage 1 to stage 5. So this is the female. So stage 1, we have absolutely nothing, right? This is basically they have not started puberty, so they're prepubertal. Then in stage 2, we have sparse growth of long, straight, downy pubic hair. All right. And then stage 3, it gets more darker, coarser, curly, and it spreads over the entire pubis. And then stage 4, this is what it looks like. And then stage 5, you might see some aspect on the inner thighs. Now, at this stage, they probably are shaving. A lot of girls like to shave because they don't like the hair down there. Don't understand that sometimes, but they don't like the hair down there. So they start shaving at a young age. And so you might have to just kind of see if there's some shaved areas. And so you have to ask them, do you shave? All right. And then for the males, here's our descriptions of males. Okay. So I'm not going to read through this, but we're looking at pubic hair and we're looking at penile enlargement as well, and looking where the pubic hair is, very similar to the ladies. All right. So now I want you to understand that they don't all go in sequence. So we can have somebody in the large stage 3, but in stage for the pubic hair, they're in stage 4. Okay. So, or vice versa, right? So it's important to make sure that when you are describing the Tanner stage of a child, you state both. You have to state both. All right. Now, there is a video on the in the module on Canvas from one of the gentlemen that I routinely look at, and he is a great example of, going through and explaining it. Now, you don't have to watch that, but I think it's helpful if you're not familiar with puberty. Now we're going to talk about precocious puberty. So precocious puberty, and this is in the endocrine chapter, and you can see the page number up there. This is when a child goes through puberty early. So this is a child who comes in and you're doing a Tanner stage and you're like, well, aren't we developing pretty fast, right? Again, that can happen. Ideally, what we see is early development or hitting puberty at 9 and hitting puberty for females at 8 or even earlier, like 6 or 7. That crazy? So signs will be, breast development and growth spurts and early getting their period really early. Um, for boys, penile and testicular enlargement early, increased muscle, hair growth spurt, and a voice change pretty early. There are two types of precocious puberty. We've got central and then we have peripheral. Central means that there is something centrally going on inside. So go back to that hypothalamus um, image from your textbook. So that means there's something that had triggered the hypothalamus to start the puberty stage or the hormone release, right? The GnRH. It could be a brain tumor. It could be a bleed. It could have been an accident. It's something inside the child from a developmental standpoint that has caused it. Peripheral puberty is something external that triggers the response. So that's ingestion of hormones, the increase of hormone, eating foods that have increased hormone, like chicken, and exposing yourself multiple times. It could be hormone injections, right? Whatever it is, it's something external that you are putting in from the peripheral. Think of from the peripheral or external that they are either consuming, or maybe it's some hair products or makeup, these things that have estrogen in it. Lots of makeup have hormones in it. That is actually causing the changes early. To test for this, we use what we call a bone age, which is just an x-ray of their hand, and you can see it here. I'm gonna get my cursor. So this is the bones of a 2-year-old, a 4-year-old, a 7-year-old, a 10-year-old, and 14-year-old, and so forth, right? And so what they do is they take an x-ray and you could tell the difference. I mean, it's distinct. You can see the difference. And what they do is they say, okay, so this is a 4-year-old, but I see the bone age of, okay, let's say a 4-year-old. Let's just say this is a 7-year-old, but I see a bone age of a 10-year-old, because they have this growth spurt that happens when they go through precocious puberty. Their bones are going to show up older than what they are. And that is an easy test to look at, is to get a bone age test. But they also probably will need to get an MRI to rule out any type of tumors or anything going on centrally if the bone age test is positive. Next, they also, oh, wait, one more thing. They also probably could do some hormone tests to see where their hormones are. But if we see that somebody actually has hit puberty, we can probably guarantee that the hormones are pretty high, right? So, but there are people who will do a hormone test as well. All right, treatment. So, treatment of this is Lupron. All right, this is an injection that they take to stop the early development of puberty. Because this is very important that we do want to stop it, because we do not want them to go through this growth spurt early, because their bones are going to fuse before they're supposed to. So we put them on Lupron, and their Lupron will keep them on until the time is appropriate for their body to go through growth spurt. And then, because if not, it's going to stunt their growth. So just imagine you go through a so-called growth spurt, but you're short, but you're not going to achieve your full potential of growth if you do it early. And so what we'll do is we'll use Lupron to suppress this, so that that doesn't happen, and then stop the Lupron when they hit an age where it's appropriate for them to grow through that growth spurt. This is a medication you probably have heard is controversial, because it is also used for children who want to go through a sex change. So we have teenagers who are male who want to be female, or female who want to be male, and when they start to hit puberty, it is very traumatic for them to have these changes happen in their body because they want to be the opposite sex. And so a lot of providers who support these children going through a sex change will put them on Lupron to suppress that because it's mentally making them upset. Now, I'm not here for the ethics and stuff. That actually is a great, when we have our debate, when we have the pediatric debates, it's a great topic for them to debate on. But I just want to let you know, you probably have probably heard about that, or just know that this medication can be used for other things that right now are controversial. All right, so the next one is a image of from your textbook about precocious puberty. So again, it's just telling you some of the things that I already told you about causes of central puberty. It can be idiopathic, but usually some congenital anomalies, trauma, cancer, radiotherapy, some type of brain insult, so forth. Precocious puberty, there are some syndromes that can actually cause it. But again, ingesting sex hormones, basically hormones. Again, that hypothyroidism can be, yeah. So I forgot to say, hypothyroidism can be a cause of a lot of sexual disorders, right? When it comes to the cycle, when it comes to um, being fertile and so forth. So just want to put that out there. We usually don't see that with children, but again, all right. And so this is just an image of that. You can take a more look at that in your book. All right. The next thing we're going to talk about is acne vulgaris. So we all know about acne. We've heard about it. We probably either you had it when you were younger or dealing with it now. It's one of those things that it's part of life, but it happens usually during puberty. It's commonly associated with it is the most common skin problem treated by physicians during adolescence. It is mostly caused by testosterone. And remember, testosterone is in boys and girls, it's just very small in girls. It basically stimulates the sebaceous glands of the skin, and they enlarge and they produce this oil and plug the pores. Comedones, I think I'm sorry, comedones usually are the results of this oily substance. It causes blackheads or whiteheads, and it can become very irritating. And it actually can become so inflamed that it can cause an infection as well. Numerous factors can affect the development of acne. It is usually, um, it can be hereditary, but it could be associated with foods. It could be associated with hygiene. Also, we've learned for females, they see like a pattern when during their cycle, a specific period of their cycle that can cause it, or if they have irregular cycles. So that, there's a lot of things that can happen. It could be from mild to severe, and it can be very debilitating. So, um, what we do for this is to tell students, or I mean, tell students, well, they are students technically, but to tell children to cleanse their skin at least twice a day, right? Kind of look at what you're eating and give them, the things like chocolate and oily foods and stuff like that that they need to try to avoid. There are medication and creams that the dermatologist can recommend to them to depending on, what's going on. Benzoyl peroxide is an antibacterial agent. Retin A is getting controversial right now because a lot of teenagers are using that for their acne, but there's something about it that dermatologists, and I can't recall it right now, but there's something about retin A that can be toxic, and they say children should not be using it all the time unless they have a reason to. So people are buying this over the counter and they're using it, and they're not being monitored appropriately. Girls, for example, will be put on birth control pills. Contraceptives can help control their periods a little bit better, and they say that actually helps with acne breakouts. All right, now we're going to go into the ages and stages. So, on how I have it set up is I'm going to talk about, like, for example, here, physical growth. And then I'm going to say the school age, and then the next slide will be adolescence. And you're going to see that pattern as I move through the last of these slides. So, school age children, um, this is a time period where things kind of slow down. We talk about that growth spurt happens in the infants, and then there's a growth spurt that happens in adolescence during puberty. But this time in between toddler, preschool, and school age in particular here, their growth slows. And so their caloric needs are less. There are varying proportions, body proportions, and heights, and sort of attitudes and personalities when it comes to this age. They're usually very steady on their feet, and they have an increase in skills and abilities and postures. However, they still have immature muscle masses, and they're still learning, their body is still learning to deal with, some coordination issues. So they're more prone to injuries, and they also can be prone to overuse. I don't know if you heard of overuse, overuse injuries, because this is where they're also getting into sports. They're very competitive, and because their muscles are so immature, they can get injured really easily. All right. So anyway, with their growth, increasing growth and growth in strength, it makes it easier for them to achieve things like balancing on a bike and climbing and other complex skills. So the world is just opening up for them. But this is also known as the awkward stage, not just because they get a little lanky as far as their growth, but also this is where they lose their teeth, primary their primary teeth, and they start to get their permanent teeth. And as you can see, the young lady in the middle. And so they get this weird lookingness stage. And this is kind of the awkward stage, or the duckling stage, because of all of this awkwardness. All right, for our adolescents, however, we got that growth spurt. We got that growth spurt. And like I said, girls, unfortunately, our muscle mass starts to peak, and then it slows down, and our fat mass goes up. And boys, it's the opposite. The fat goes down and the muscle mass goes up. They have an increased endurance and strength in adolescence, and they become very precise with their hand and eye coordination and dexterity. So let's talk about the developmental stages or developmental theories here. So we're going to let's start with Erickson. Okay. So Erickson, as you see, is industry versus inferiority, and then identity versus role confusion. So a sense of identity, or sometimes we call it a sense of accomplishment, develops between 6 years old and can and completes somewhere in adolescence. School age children are eager to develop skills and participate in meaningful and socially useful work. Their interests can expand all throughout their school age time. They want to be engaged in tasks and carry it through completion. So to develop a sense of industry, early on, you'll hear them, I can do it. Let me do it. I got it. I got it. Very helpful. Very helpful. Sometimes very in the way, but this is a very important stage where they need to develop that sense of achievement, develop that sense of industry. Because if we strike them down and say, hey, kids aren't supposed to be here, go sit down, go play, go do this, you're in the way, that creates a sense of inferiority. Okay. Or God forbid somebody says, well, you did a horrible job. What do you think you're doing? And you know that there are people who have done that to children all the time. And that makes them feel inferior. And they grow up without a sense of being able to achieve anything. I can't do anything. I'm stupid. I was always told that. And that is that industry versus inferiority. For our adolescents, in identity versus role confusion. Very simple. The task of identity formation. They want to develop who they are in this world. Where do I fit in this world? Their mindset is all about getting out there and creating role for themselves, right? And if they really don't form an identity of who they are in this world, they can be very confused. And we've seen people probably confused, and we're like, I think they're confused. That I don't think they know who they are, like whatever the case may be. Not in a hierarchy standpoint, but just they have no focus, they have no direction. And that's just because they haven't really just develop their own self concept. Now, self concept is something else that we are talking a lot about when it comes to adolescence. So that's probably why I'm saying that, but it's not here on this slide. But that's the psychosocial development here. We want them to achieve that identity, instead of becoming very confused on where they fit into this world. All right. So I'm just going to go on down. So let's go to Kohlberg. So Kohlberg is that moral that we've been talking about. And Kohlberg, um, for the school age, they are still in stage one and stage two, right? That whatever you say goes bad versus good. You guys set the rules, but then they're actually starting to go into that second stage of pre-conventional stage. And again, that stage is usually 6 or 7 year olds may start to interpret accidents or misfortunes as punishment for bad acts. But then as they get older, they're influenced by peers and other relationships, or they've been exposed to different things. And they may say, you know, you said that I wasn't supposed to do certain things, but I saw such and such. Not so sure if that's true. I wanna laugh every time I say that because it's so funny because that's just like them, a 10-year-old or an 8-year-old. It's because they get out there in the world and they're influenced by other people, other things. They begin to get a sense of what may be true or may not be true. So the textbook calls this individualism, right? They're able to judge or enact by intentions or look from other thoughts of views rather than just what mommy and daddy says or whoever their primary caregiver is. So they may actually stand up to you. They may question you what you're doing just simply because they know that that may not always be true. And so they start to move away from that authoritarian um, viewpoint. All right. At adolescence, however, they kind of are in that conventional stage because it's all about their peers, right? So this is where the social norms can come into play. This is where they are going to be more impressionable from a society standpoint. And so now they're like, oh, I don't know. I might want to, from a moral standpoint, if something's pulling on them, they're going to start to say, well, if I do this, I could get in trouble. What are other people going to think? They're not quite sure if this is socially right, because they're thinking about, well, what's in it for me, right? So, unfortunately, that is where they are in that conventional stage three. So, they call that the principled moral reason, right? So, what's the point here? So, make sure you take a look at that one. Now, the Piaget, this is our cognitive theory. This for our school age, we have the concrete operational thinking. So this is make sure. Well, I know what it is, but concrete operational thinking is they think very concrete. Okay, everything is in a particular order. We do not pass go. We do not collect $100. This is where we go. So everything is black and white. Everything, they can't really pull in other things and be able to look at it from a different point of view. Everything is concrete. So they used our process to experience events and actions in that way. We test this by using the concept of conservation. Now, there is a video that I am going to post in your module, and I want you to look at it because it really makes sense on how we do it. And it's the water test or the money test. And literally, all you do is you have two different glasses, two different sizes. One is tall and skinny, and one is short and wide. And you just take one and you tell them, okay, so do you see the glasses? Do they look different? They said yes. And so then you pour the glass in, the water in to the other one, and then you say, does this one have more, or does this one have less? And a child who has not reached the concept of conservation is still operating in the concrete operational thinking. Okay. But children who have, they actually are going to say, well, just because you did that doesn't mean that. And they just start rationalizing all these different things. So watch the video. I love that video. I usually show it in class, and it's classic. So I think it'll be a great video for you to watch to make sure you clearly understand the concept of conservation. And then lastly, for our formal operational thinking, that's our adolescence. This is the abstract thinking, right? To really conceptualize your thought process from a cognitive standpoint when you're thinking about things. And that is something that you typically want to see in your adolescence. And you can easily determine that by just having a conversation with them. So, one thing I want to challenge you to do is to think about a situation where Erickson's stages, Erickson, our psychosocial, would apply in a hospital, because children are in isolation, children are confined, they're dealing with a lot of things and stresses that we've talked about before, and it can affect them from an Erickson standpoint. So, think of a situation, and then how can a nurse contribute to finding industry or identity? All right. So, school age children. So, now we're going to talk about social and behavioral development. So, other behaviors that we may see for school age is their social development with peers, making sure it's a positive things. We may see their personality really start to form as they go through this stage. The outside influences are really important to monitor, make sure they have a positive influence. Their play is definitely going to change. It can be more physical, intellectual, or fantasy. They like to see, or do they prefer to be solitary or in groups? This is usually where we see Girl Scout, Boy Scouts. And if they are playing with people, is the structure and rules, first base, second base, and or making things up as they go. Body image is also a big thing. You might see them dressing up like a parents or pretending, but then as they get older, they may start to dress in the way that kind of is showing a little bit of their personality. And it's not unusual to see children uh, who are gay, who identify as a different sex, because they're going to start to want to put on different clothing, or and they also may start to reject certain clothing. And it's really important for parents to get some counseling on that, because that may become a tug of war. And then for our adolescents, it's a little different. So the social and behavioral issues are really going to be around some milestones here. So I have stress there because they're under a lot of stress. They're under a lot of stress. Stress for relationships, stress for school, stress for college, stress for positive relationships with other or both the sexes. There's a lot of stress that happens in adolescence, and going through puberty itself is stressful. And so they have all these things that they have to think about, and all these things that we need to ask them questions about. And they may actually begin to start work at this time, and work may be positive or negative, right? Work, a positive thing is they learn how to go into a job and be able to keep a job and take orders from somebody and make money and see the benefits of making money, and how do they manage their money, right? And the negatives could be they have to work because they have no other choice, because they have to bring money to the house, and then the family's telling them to drop out of school, right? So it can be a negative or a positive. All right, so hygiene. So with hygiene for our school age, very straightforward. I'm going to more so focus on sleep hygiene than the other stuff, but I'm going to mention that stuff first. So again, the permanent teeth are coming in, the primary teeth are falling out. They should be gone by middle age, and they should definitely be going to the dentist at least twice a year and getting fluoride treatments. They should be self brushing their teeth every 2 times a day, and they should be doing it independently. Sleep hygiene. So they should be sleeping for at least 10 to 12 hours during this stage. The same thing for adolescents, also, by the way. But sleep hygiene is important, especially in today's society, because we have a lot of challenging things as far as technology, eating bad habits and stuff like this. So this image here is something I pulled off the internet, and it shows poor versus good sleep hygiene. So poor sleep hygiene, if they have excess light in the room, if they're using devices before they go to bed, if the room is too warm, believe it or not, a cool room, because our body temperature drops, is better for us than a hot room. Um, Eating about an hour before bedtime, consuming caffeine even during the day. But these are the things that hinder good sleep, and these are the things that promote good sleep. So, having water, a little bit is fine. Reading a story before bedtime, using a fan, using light blocking things, and not using, obviously, using screen time beforehand. These really do affect our brains. I can't say that I'm doing all these things perfectly, but I do notice that when I don't, I get better sleep. And then when I do use like TV or electronics before going to bed. All right. So for adolescents, hygiene, some of the hygiene concerns are their body art and piercings, because they can get tattoos at 16. And our challenge there is that they need to realize that this is a wound. This is cute and everything, I guess, but this is a wound, and how do you take care of the wound? Nutrition, they need extra vitamins because they're going through a growth spurt, and a lot of times they're trying to do the opposite with dieting, and they're trying to lose weight instead of supporting their body for the caloric needs that it needs. Sleep, they should have 8 hours of sleep, at least. Exercise is varied, but overall, they need to decrease the screen time just the same and be outside more, which is very difficult to make adolescents do that. And the dental care will continue. So nutrition, from a nutrition standpoint, we're going to talk about my plate in a second. They should have at least an hour of physical activity. They should definitely be in sports if the family can afford it. So I understand that sports are expensive. I paid thousands, and I mean thousands of dollars for the sports that my daughter was in. And I'm glad to this day. Okay. Because from a physique standpoint, even though the college put the weight on, no, college put the weight on, but she was a size zero. Maybe the most Nina was probably a size five. I couldn't find clothes to fit her. But that's because she was a gymnast, and she really got up there in gymnastics and cheer. So she was very, very, very physique. Um, and I think it does a lot, not only for them from a physical standpoint, but from a social standpoint and from a psychological standpoint, to be engaged in activity and to exercise at least 1 hour or once a day is really important. So encouraging them to be involved in sports and using my plate as a guide is what they should be doing. Um, and my plate here, this is the guide that the USDA has recommended to kind of for their caloric intake, 2,800 calories a day from these food groups. You do need to know the food groups. There's one in particular that is controversial, which is the grains, because we do have people who have celiac disease, and can't eat the gluten and stuff like that. So substitutions for that is important. But nonetheless, fruits, vegetable grains, and when they say grains, they're talking about starches. So there's other starches that they can use, and then protein and dairy. Okay, so now we're going to talk about childhood obesity. So childhood obesity is a huge problem. Okay. It means that the child has a BMI greater than or equal to 95th percentile on the curve. Remember, we check for BMI as our indicator for obesity as of right now. And We start at age 2, I said, at age 2. Um, there are a lot of reasons why children are obese. Black and Hispanic communities have higher prevalence rates than others. There is a video on the next slide. Um, but moving forward, and that's this video is just to kind of give you it's one program that somebody used to make a difference in her community. But there are numerous factors. There's appetite regulation things, so peptides and a network of hormones that basically signal hunger are different from in some people than others. All right. You've probably heard of the food noise that happens when or goes away when somebody is on a GLP-1 medication, whether it's Wegovy or whether it's Zepbound, then Sandosaxon, and there was another one. And there's another one I think come out. But basically, you know what I'm talking about, right? The weight loss drugs. And it just goes away. It just goes completely away, right? Then there's also social and cultural factors as far as being able to, the type of foods that you're culturally you eat could be more starchy than foods that you need in order to maintain weight. Behavioral, meaning people eat more when they're happy or they're sad, right? Their activity level, sedentary lifestyles of the children is really starting to be a problem. Environmental, meaning food deserts, do they have access to these foods? Do they have access to these foods? And then there could be some underlying diseases like diabetes or respiratory problems that make it very difficult for them to achieve an activity level in order to be able to make a difference in their physical body and their caloric expenditure. All right. So there are some treatments that are available. I'm actually going to go to the next slide because I think it's listed here as well. Because I want to talk about first some complications. So type 2 diabetes is one. They also can develop bow-leggedness or skeletal problems where the bones are bending a little bit because of the heaviness of the weight. They also can develop knee problems earlier on in life. They also can develop non-alcoholic fatty liver disease, sleep apnea, and that also can lead to, if they have sleep apnea that's not taken care of, it also can lead to cardiac issues. And then hypertension. Hypertension. Hypertension is a big issue. A lot of children now are dealing with cardiac disease, and they are actually taking cardiac medications and medications for to lower their cholesterol in school age, in school age ages. So that's a big problem. Recommendations and management, diet, finding a diet that works for you. Not dieting, but finding a diet, an eating way that works for you. And to be honest, in order for this to work, the whole family has to go through this. There have been some clips I've watched in the past that have discussed how um, they have gone and they have taken families to grocery stores just to kind of just see what the mom is looking at. And there's certain vegetables that they would never touch. They go straight to the cereal aisle, the pasta aisle, stuff like that. And these families are not even thinking about eating fresh whole foods. And because they also don't know how to make it. And there's ways that you can make things that actually are good. So moving on to that, the whole family has to engage in this change because the child usually obviously can't cook food for themselves, and it's what's being given to them that's causing the diet issue. Activity needs to increase. Again, that's a whole family approach. Going out for a walk after you have dinner, doing something of some activity, and turning off those electronics. Behavioral therapy and counseling always is something that's recommended. There are specialized groups or camps for children who are working through a change in this lifestyle. Community programs is that's that video here. You can click on it if you want to look at it. She's basically talking about what she does for her elementary children in California. And then last but not least, we have surgery. Okay. So surgery, bariatric surgery is being done on children to help them lose weight. So that's one of the assignment options that you can do, and I'll talk about that in a second. All right. So now we're going to go into school age safety. So school age safety. So safety for school age, there's a couple things that kind of jump out. So risky behavior due to peer pressure. So people being pressured to do things that they shouldn't do. Bullying and abuse is still a problem. So bullying is always a problem, but abuse is still a problem because you usually do have pedophilers and people who are watching children who are, for example, coming home by themselves because this is a dual working household and they become, as you can see me circling here, latchkey kids. Latchkey kids increases the number are increasing in number because both parents are working and increasing and the also the increasing number of single parent homes. So they may or may not be able to have or participate in an after school program, which is usually what's used for parents who cannot be home when their children get off the school bus. Okay. So there are a number of child care centers and programs that will watch the children until the parents can come pick them up from that location so that they're not home alone or don't have to be a latchkey kid. And just so that, well, let me just tell you. So the rules here in Georgia are children are basically can be left alone. Let me make sure I have this right. Children under 8 cannot be left alone. So they have to be at least 8 years old. And then starting at 9 to 12, they can be left alone for no longer than 2 hours. And at 13, they can be left alone for longer periods as long as the parents think that they can handle it, right? Longer periods doesn't mean like overnight. So that's the rule in Georgia to prevent a parent being um, called on, by defects. So that's the age limit. So 8 is basically second or third grade, and so parents have to figure out what they're going to do for children who are starting school at age 6. All right. So going back to the list, bullying is self-explanatory and abuse is self-explanatory. School phobia. So this has many causes. A lot of children are beginning to not feel safe in schools, or they are afraid to leave home. Now, this has to do with media, school shootings, the temperament of the child, and just a lot of psychological stuff and children starting to be afraid of school. So parents are pulling them out of school and homeschooling, which isn't a bad thing, but is this what's best for the child if they start to develop a school phobia? So it's really important to get to the bottom of it real quick and get the child matriculated back to the school if that's what the ultimate goal is. Um, but school phobia is starting to rear its ugly head, and a lot of it has to deal with the harm that they're noticing or the environment of the schools that's not really conducive to learning. So helmet safety is a big one because remember I said they're riding those two wheelers, they can balance on the bike. And so helmet safety, so protect for head injury, learning how to cross the street. You will not be surprised how many children do not know how to cross the street, pedestrian safety, in other words. Firearms, I'm beating it like a dead horse, but very important. Parents must lock up their guns, all right, and their firearms and their weapons. Water safety still is an issue here because of the peer pressure to be able to get into the deep end, to be able to do what other people are doing, and that can actually cause some harm and hopefully not a drowning episode. And I've already talked about after school care. So let's jump to adolescence. Safety is pretty self-explanatory here. Sexually transmitted disease if they become sexually active, self-harm, suicide. There's what we're going to talk about in a second. That body art, those tattoos that are wounds that can get infected because they're not taking care of it. Violence is another thing we're going to talk about as well. And sports injuries because it's a lot of pressure to perform when you're in certain sports and they can tend to get hurt very easily. And then driving. Being a responsible driver is a lot of pressure for a teenager, and sometimes they don't make the best drivers. Let's just say that. So that can actually be a safety thing with children, with adolescents in particular. So substance use, we got to talk about substance use. It's a biggie. It's a biggie. 1 in 5 adolescents experiment with some form of substance at one point in time in their school life. All right. So there's a host of drugs that are out there, but vaping is becoming the biggest culprit. They are vaping so much. They are very addicted to vaping, and now there's this syndrome that's associated with vaping. Actually, two syndromes. There's two syndromes associated with vaping, and it's affecting these children early on in their 20s. Um, I have the poison control there. Just as a reminder that poison control is very important as a resource, not only for parents, but healthcare professionals. Poison control is our go-to source for what am I dealing with? What do I need to manage? When do I need to take them in? What are my lab results, etc. Teens.drugabuse.gov is a website reference. I hope it's still live, and it's where we go to figure out what did you take. And if we have an idea of what they took and we can look it up, that would be great. And because they go by all these different names now, I can't keep up. And 9 out of 10 smokers usually say they started smoking by age 18. And I know that's an old statistic, but they haven't really updated the statistic with kids yet. I know that they're focusing a lot on vaping right now, but tobacco, a lot of kids basically start early in middle school, and it increases the usage of tobacco increases in high school. And then there's other things like I don't even know how to get their hands on Toradol and ketamine, um, and so forth. So I might have to get something to upload. I mean to update this slide, but substance use is huge, as well as violence. So, not necessarily violence in general, like school shootings, but there's a lot of violence that's happening to children from relationships, okay? Um, from just people just harming other people because they are prejudiced or racist, um, being in areas that are unsafe, where there's a lot of crime and being subjected to that type of violence. So they are really seeing a lot of violence. So violence is another big thing that they're focusing on when it comes to children. So for nurses, we need to understand that yes, we do need to screen them, but we also need to start screening them to how much violence that they're being subjected to. And there are actually assessment tools out there now that we will give them a score called an ACE score. So the ACE score tells us how much adversity or how much violence or negativity has a child experienced. And then depending on the score depends on their percentage or the risk that this child will grow up with chronic diseases. There's a strong correlation, and because of that, if we could deal with the level of violence and adversity that these children have to deal with, we might be able to impact the health of an adult later on in the future. So nurses should assess this confidentially, obviously. Again, there are tools. We should screen children regardless. One of the populations, actually, there's two. There's two populations that are more at risk. The LGBTQ population is more at risk for experiencing violence, and ethnic minorities are more at risk for experiencing violence. Okay, so box 7.5 is just factors contributing to adolescent violence, but it's always important to ask about their sexual preferences. Um, and for example, for LGBTQ, then you want to ask about their sexual preferences. If do tell you that they are gay, whatever the case may be, then you need to talk to them. Hey, do your parents know? And if they talk to you about coming out, they really should have a plan before they come out, meaning they should have a safety spot. This is meaning the child should be connected with a resource if they feel that it might go bad. So this is I don't know if it still exists here in Georgia, but this is one here in Georgia where they will actually take children in, and there's a few of them. When a child is about to come out, and if they get kicked out, so that's what happens. They get kicked out, then they're in these situations where they're homeless. They don't have anywhere to go, and they start being manipulated by people that they should not be around, right? So having a plan before they come out, where they can stay safe and get connected to resources, so that they don't get endangered. All right. For African Americans, or other ethnic communities, this is a situation where they need to find ways to deal with adversity, so that they don't necessarily increase their chances of one, dealing with it negatively, and then increasing their chances of chronic disease. There's so many studies on this, and I think it's absolutely fascinating. But from a pediatric standpoint, just know that our job is to assess them, and knowing that these particular group of children, if they have these experiences and have these situations, that they are more prone to violence, more prone to hurt, and then later on prone to chronic diseases. Right. So now we're going to talk about, unfortunately, still not that great, but teen suicide. So teen suicide is something that we all know of. I know you guys have talked about suicide, depression. There's a difference between ideation versus attempt. That's important to distinguish. If you have a child who came in and said, I really want to hurt myself, or they did something and they hurt themselves, and now it's pretty obvious. So ideation is that they they have this idea that they want to do it versus an actual attempt. Um, the preferred methods, usually the preferred methods are gunshots. The highest one that we see the most is they ingest drugs, because they can get access to stuff like CVS and Walgreens, and they can go buy a bottle of Tylenol or aspirin or Motrin. Tylenol, yeah, Tylenol, aspirin, or Motrin. Those are the three. And they will just take the whole bottle or take half of the bottle or whatever the case may be, and then freak out and then call somebody, or somebody finds them. Boys tend to be a little bit more violent than girls. Girls will cut more, and take medications. Boys, sometimes, if they're really serious, they will use a gun. Um, so it's also important there are certain signs that will tell us that somebody is possibly going to be a harm to themselves or harm to others. And the screening tools. So there's a screening tool in the next slide, which is the ASQ. It is the one we use at CHOA. It also was created by a nurse. She did a fantastic job. It's very easy to administer, and we're going to talk about in just a second. So remember about that 13-year-old rule that I talked about, that you can't talk to the family about what's going on with the child if they're 13 or older. Well, in this situation, if a teenager harms themselves, is declared a 1013, then that's off the table. Parents know everything. So that's no longer in existence. That's only for STDs, pregnancies, and so forth. But if they harm themselves, then they're 1013, and then that's all. It does not apply. Before I jump to the next one, I want to tell you this TED Talk. So this is a TED Talk, and so you could learn more about the suicide screening here. That was formed by the nurse who was in emergency department. If you want to look at that video, this is a TED Talk of Sadie Penn. Was a teenager who attempted to kill herself, unsuccessful as you can see. But she did a conversation, a TED talk about that, and I thought it was pretty good. Now, just disclaimer, if this is a sensitive topic for you, just tread cautiously. But I like to give you guys some insight from people and things that are more than me just saying words and following script on a PowerPoint, right? So sometimes watching things gives you a little bit more close familiarity, and sometimes it can help you better on the test. So let's go to the last slide, which is the actual tool. So this is the ASQ, it's suicide risk screening tool. There's a 4 questions at the top. In the past few weeks, have you wished you were dead? Have you felt that you or your family would be better off if you were dead? And I've had to ask these questions. Have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If if the child says yes to any of those questions, there are suicide risk. So at that point, you are required to make sure, one, that you notify. First of all, you have to you have to keep them in your eyesight the entire time at that point. Um, you can ask number 5, just let you know, are you having thoughts of killing yourself right now? And if they say yes, okay. So you can't leave. You have to get somebody to if somebody to come, and it can't be a parent. You have to have somebody who has been trained on monitoring somebody who is a suicide risk. So it could be another nurse, it could be a charge nurse, you could be a tech, something like that. You have to notify the doctor. They have to get an order to make them a suicide risk. And then we have to search them, take away their phones, basically eliminate any outside contact at all. So we take away the phone in the room. We look for anything in the room that they could probably kill themselves. So the trash can comes out because they can suffocate themselves with the bag, any ropes, when they order food, they can't have a fork and a knife. I'm just kind of going down the things so you kind of get the gist of what it is, right? You want to make sure there's nothing that they have access to that can harm themselves. If they want to go take a shower or go to the bathroom, unfortunately, it's no longer private. Um, and they have to change out into purple. So there's these garments that they put on, and it's purple. So purple is the universal color for suicide risk. So they have to wear that. And of course, we have to get their caregivers, right? And notify the psychiatrist on staff who will then determine if they are 1013 and get the ball rolling, right? They cannot leave, they cannot change their mind about, you know what, I didn't mean to say that, it's too late, right? So we have to find a whole protocol. So for you to remember, you do have to search them. You need to make sure the room is clear of anything from outside contact and anything that they can potentially harm themselves with. And you cannot leave their side. There has to be somebody there who's trained to monitor somebody who's at suicide risk. And the nurse must notify the physician so that proper things can start to happen, to have them properly evaluated. Okay, so this is the end of the slides. Let me know if you have any questions, and I will talk to you soon.